Once you have a patient of an acute visual loss in your emergency department, and you usually give you a history of the presenting complaints as the acute kind of a vision loss that was observed by the patient when he woke up, you would basically categorize this patient as one of the confrontational case of the ischemic optic neuropathy, or the differential diagnosis would include this acute anterior ischemic optic neuropathy at your hand. So you have to investigate these patients in detail if you have to get to know the patients. Now there are the different categorizations that we're dealing with. We have the non-arteritic kind of the ischemic optic neuropathies, and on the other hand, we have the arteritic sorts of the ischemic optic neuropathies. In this particular section, we're just focusing on the non-arteritic kind of anterior ischemic optic neuropathies. So basically, when we talk about the causative factors for the development of this non-arteritic kind of ischemic optic neuropathy, we say that it's basically an idiopathic condition. The causative factors are not quite well known. The causative factors that are known, or that may be one of the reasons for the development of arthritis or for the development of ischemic conditions in the patient, can be one of the factors, that is the anatomical features that make the person predisposed to the development of this ischemic condition. For example, when we perform fundoscopy of ophthalmoscopy in such patients, even the good eye or the better eye, we see that there is a crowding phenomena that is observed at the optic disc. Now, how do we say that the disc is crowded? Now, just to give you an overview, the place where the optic nerve is entering the bulb or the orbital bulb is basically 20 to 30% larger than the optic nerve itself. In a lot of patients, in a lot of people, this area where the optic nerve is entering the retina, that is quite much crowded, and that is again going to make the person more prone to the development of such ischemic conditions. Even a minute hindrance in the blood circulation would result in an ischemic kind of a condition in such patients. So this is one of the anatomical reasons that the patient can develop an ischemic kind of a condition, even if no other systemic malfunctions are found in such patients. So over here in this particular section, we'll be dealing with the different types of anterior ischemic optic neuropathies. How do we differentiate them clinically? And then the clinical features that are particular to this non-arteritic kind of anterior ischemic optic neuropathy, that will be discussed in detail over here. Because that will be the differentiating point between the arteritic kind and the non-arteritic sorts of the ischemic optic neuropathies over here. And then we'll move on to the diagnosis. How do we diagnose whether the patient is of a non-arteritic type or whether he or she is of an arteritic kind of ischemic neuropathies over here. The treatment modalities would also be discussed in detail over here in this particularly second section. So the ischemic optic neuropathies, we have the non-arteritic ischemic optic neuropathies. As we can see, it can be the systemic factors that are responsible for the development of this non-arteritic kind of ischemic optic neuropathies. When we say this, there are these systemic factors, mainly we talk about the diabetes. We can say it can be the high cholesterol levels, it can be the hypertension. So if there is any predisposition to all of these conditions, or the patient is a diagnosed case of hypertension, diabetes mellitus, and high cholesterol levels, he's more prone to the development of this ischemic kind of a condition in the optic nerve. So over here we have the anterior ischemic optic neuropathy with a swollen optic disc. Whenever we say we have this swollen optic disc, is basically the crowdiness phenomena that we have already talked about. It's basically an anatomical predisposition towards the development of the ischemia. It's this crowdiness is basically due to the lesser diameter of the area that allows the optic nerve to enter the retina. It's usually 20 to 30% larger than the nerve itself, but in a lot of patients it's not, and that is the crowdiness phenomena that is responsible for the development of these ischemic conditions over here. On the other hand, we have the posterior ischemic optic neuropathy with a normal optic disc. So if it's a normal optic disc and it's a non-arteritic kind of an ischemic optic neuropathy, then the reasons might be systemic in origin. The systemic reasons would include the hypertension, it would include the high cholesterol levels, it would include the diabetes mellitus. So all of these conditions can make the person more prone to the development of this ischemic kind of condition that we talk about. The arteritic ischemic optic neuropathies, one of the major causative factors that we usually encounter is the vasculitis caused by the condition which is known as the giant cell arteritis in these individuals. The anterior ischemic optic neuropathy with a swollen optic disc, again, it can be a person who was already predisposed by a crowded disc and he again developed a vasculitis due to some other reasons or developed giant cell arteritis conditions due to some other reasons. The posterior ischemic optic neuropathy with a normal optic disc, so it can be a person with a normal optic disc, no anatomical predispositions, but still he developed this ischemic condition due to the development of giant cell arteritis or temporal arteritis or due to any other inflammatory conditions in the person. So these are the typical pictures. This was the crowdiness phenomena, that is the swelling of the optic disc is seen in both of these conditions. The picture is quite similar. You cannot basically distinguish just looking at the optic disc or just looking back at the fundus. You cannot distinguish whether it is a non-arteritic kind or whether it is an arteritic kind. You're just going to see whether it is an ischemic condition with a swollen disc or whether it is an ischemic condition with an optic nerve disc, which appears quite normal in these individuals, but still the person is suffering from ischemia. So these are the typical fundoscopic features that we usually observe in these patients of ischemic optic neuropathy. The clinical features of non-arteritic kind would include the sudden painless monocular loss of visual acuity. So this is the presenting complaint even by the patient. The history would include the sudden loss of vision, the painless loss of vision, usually observed after waking up, unilateral condition, usually in a lot of cases. So this is the presenting complaint. The history of presenting complaint would include it was not a gradual onset, it was an acute onset in this individual that was observed or that was seen with the loss of the visual acuity in the individual. The visual field defect usually inferior altitudinal but can be central, paracentric, or it can be arcuate as well. So whenever you perform those Hirschberg's manual testings to get to know the visual field in a person, you would see that there is an arcuate loss of the visual field, altitudinal, central, or paracentric loss of visual field. There would be dyschromatopsia. Contrast sensitivity or color sensitivity would also be affected in these individuals. Diffuse or sectoral disc swelling, that is pallid edema. So when you just focus on the optic disc, you would see that there is an edema, there is a swelling, there is this crowdiness phenomena that is observed in these individuals. The pallor of the optic disc would be lost in these individuals. Even of the other eye, it is typically small or the cup is absent in these individuals. The optic cup, the disc that we talked about, that would be absent because of the swelling of the optic disc. That would be absent. So these are the particular clinical features or the fundoscopic findings, because fundoscopy is the mainstay when we see a person of visual loss or a decrease in the visual acuity, a significant decrease in the visual acuity. We'd observe we'd inspect the other features, obviously the lens, all of the other features, but still we're going to perform fundoscopy or retinoscopy in these individuals. Frequently associated with splinter hemorrhages. So a lot of hemorrhages are also observed due to the blood supply that is hindered at the retinal level. The investigations would include the routine investigations in the individual. The lipid profile is again very important just to have a look at it in these individuals. And then we'd also see the blood pressure and the cardiac evaluation to be performed in these individuals. ESR, why are we performing the ESR? just to rule out the arthritic kind. The ESR would be raised in inflammatory conditions, in autoimmune diseases. For example, when we talked about the giant cell arthritis to be one of the causative factors for the development, we would also perform the BP and the cardiac evaluation just to see the systemic causative factors that can be responsible for the development of the non-arteritic kind of the ischemic optic neuropathy. And on the other hand, we're also going to rule out how are we going to differentiate clinically on investigations whether it is an arthritic kind or whether it is a non-arthritic kind of giant cell ischemic optic neuropathy. It is the ESR that would be the mainstay over here when we talk about it. MRI, so diagnostic imagings are again very important, just to have a look whether any other significant infarcts have taken place in the brain or not, whether the occipital cortex is involved due to this ischemic attack or not. Sometimes it is a through and through phenomena. It is even an anterior ischemic optic neuropathy coupled up with the posterior ischemic optic neuropathy, as well as it can be a condition that is also affecting the visual cortex. So we're going to rule that out by performing these imaging techniques in these individuals. There are some other investigations, for example, FFAs, that is the fluorescein angiographies that are performed in these individuals. The fluorescein fundus angiographies in early stage shows the filling defects in the optic disc, the peripapillary choroid plexus, this is the peripapillary choroid plexus that is seen in these individuals, which is also termed as the choroidal watershed area. So these are the particular findings, or these are the particular filling defects that we'd be observing in the fundus angiography in these individuals. The treatment of this non-arteritic kind of anterior ischemic optic neuropathy, obviously, it is to find out the causative factors. If it is the systemic factors, that is the hypertension, diabetes, or the high cholesterol levels, we'd be treating or we'd be stabilizing the patient systemically. Or whether it can be the anatomical features that are making the person more prone to the development, we cannot hinder that process in these individuals. No proven definitive treatment for this purpose, because we cannot treat the anatomical defects in the individuals. It's only at the systemic level that we can intervene in these individuals. So the main focus in these individuals would be to make the patient more stabilized at the systemic level. The blood pressure levels should be controlled, the diabetes should be under control, and then the cholesterol levels should also be at the normal levels. The aspirin, levodopa, and carbidopa. So these are some of the experimental drugs that are given in a lot of individuals. Sometimes there is a drug interaction that is reported in a lot of cases. A lot of people who have been using the oral erectile dysfunction drugs have been reported to come up with this non-arteritic kind of ischemic optic neuropathy. So it can be this drug interaction, and people should be aware if they are on these kind of drugs. They should be well aware that there are a lot of side effects to these drugs as well. The hyperbaric topical brimonidine is one of the experimental drugs which is given along with that. The surgical treatment would include the transvitreal optic neurotomy. The nasal margins of the disc widen the scleral canal in these individuals. The vitrectomy to reduce the episcleral traction. So one of the approach can be this vitrectomy kind of a procedure that is performed. Ischemic optic neuropathy decompression trials are given and shows no effect of surgery on the visual outcomes of these individuals. So this is the range of the surgical treatments, which ranges to basically depressurize the compartment for the optic nerve to have the better blood flow to the optic nerve and to retain the functionality of the optic nerve in these individuals who are more prone genetically or anatomically towards the development of this ischemic condition in the individuals. So in this section, mainly we focused on one of the kinds of the ischemic optic neuropathy known as the non-arteritic kind, in which the person is not suffering from some sort of giant cell arthritis or any other inflammatory conditions, but still he develops those ischemic changes. And how can we deal or treat these patients either surgically or medically? So that is the end of this section. Thank you for watching sqadia.com.